Hi, everybody. Good afternoon. Thank you for being here. I'm Dr. Navas. I'm the pulmonologist that take care of most of the neuromuscular kids at Nemours Children's Hospital. It's a pleasure being here today, especially because I have some beautiful faces of kids that I take care of, and it's amazing to see them outside of the hospital setting. So I have to say, like Dr. Finkel was saying this morning, this SMA world and the drugs has been a very revolutionary thing, and in pulmonary also. Probably 4 years ago, if I give this talk, we will be talking about kids with type 1 being on trach and vent, and that's not what we're doing now. It's really amazing what is going on, and it's so interesting how probably everything I'm gonna say today in 3 years is gonna be probably different. So it's really exciting what is going on. And I'm very passionate about taking care of kids with SMA and general older neuromuscular patients. Nothing to disclosure. So what are we gonna do is, they told me to prepare a 15 to 20 minutes talk. I struggle a little bit because the pulmonary topic is kind of a little bit difficult to do short, but I promise I will be very concise of the important things. So we're gonna do, we're gonna talk about a little bit of pathophysiology of the respiratory impairment in SMA, and we're gonna navigate a little bit on, okay, so what tests we order and then how we manage the kids. Why do you need to see a pulmonologist is the question. So spinal muscular atrophy, muscle weakness has been associated with pulmonary impairment, and breathing issues is one of the most common complications this patient presents. So, and it's actually one that, respiratory issues is one of the ones that compromise them more. So it's very important that patients that have spinal muscular atrophy has confidence in their pulmonologist, has a sick plan to follow, are very comfortable and feel very comfortable on what they are doing in their house and have all their questions answered, because that makes a big difference on the outcome of these patients. So the general problem that we have is muscle weakness, and that's have a direct impact on the pulmonary status. Hypotonia is the fancy word for muscle weakness, and what I'm gonna do now is we're gonna talk about specific weakness, but relative to the pulmonary. So when we have one of the muscle groups that are affected are the bulbar muscle. These are the muscles like nutritionist was saying, Kelly was talking about the larynx and the pharynx muscles. So we see most in type 1, but some kids with type 2, we can see dysphagia, which is problem in swallowing. And in the pulmonary world, this is very important because when you have issues swallowing, as we were mentioning before, we can have aspiration. So the food can go the wrong way. The water, the food, and the saliva are actually really irritants to your airway, and when this touch your airways and your lungs, it really creates a lot of damage, and we can be handling serious infection and aspiration events. So I'm very aggressive of trying to find out if that's a problem, because that's part of the pulmonary care in patients with spinal muscular atrophy. The other thing that happened, and Kelly already talked about this, is we have to start recognizing when it's a problem to eat and when the patient is really losing weight and needs a little bit of help. When we have also bulbar muscle weakness, we can be facing sleep problems. So when we sleep, basically we breathe mainly with the diaphragm, and our muscles are relaxed and sleeping, but our upper airway is actually open and patent. Who do that is part of the muscles that control the airway, the abductors of the airway. So if we have weakness, sometimes at nighttime the upper airway can collapse, and then the patient can present evidence of obstruction when they go to the sleep lab. The symptoms that I kind of screen for is snoring at nighttime. During the snoring, is the patient doing some pausing breathing? If kids are a little bit older, they can tell you headaches in the morning, needing a nap during the day, mood issue, poor sleep, poor school performance, things like that can guide us a little bit in terms of if the patient is having sleep problems, and then we take them to the sleep lab to be tested. The other issue with this upper airway muscle weakness is the appearance of weak cough. And then you will think why it's actually the cough affected by this. So the mechanism of the cough is initially we will take a big breath, and then to keep that air in our lungs, we basically shut down our glottis. So if we have weakness here, the glottis cannot close so tightly, and then we're not going to be able to have a strong cough. And we're going to talk about that a little bit later. The other group of muscles that can get affected are the muscle of the intercostal, so the ones that are between your ribs, and the diaphragm. So we see, again, weak cough when we have hypotonia of these muscles. And the reason is we were not able to take that big breath to generate big pressures and cough effectively. The problem with that is that the secretions can get backed up in the airways, and then with time, those secretions can actually cause trouble. The way I try to explain to some of my older SMA kids is if you're playing in your house and you like slime, oh, yeah, I like slime, okay. So what happens if you forget to put them away the next day and they're, well, it looks a little bit messed up, so I put water on it to dilute it a little bit better. Say, well, that's happened when mucus stay in your airways for a very long time. It becomes more sticky and it becomes more hard to mobilize, and then it can collapse some of the small airway, small alveoli, and cause hypoxia. So we really need to make sure that we keep moving that mucus. We produce 10 to 100 cc's of mucus per day that we really mobilize all the time. We just don't notice that we do it. So it's very important that we keep things moving. The other thing is, and I said before, the main muscle that commands the sleep is the diaphragm. So when we're sleeping, basically everything is relaxed. The diaphragm is the one that is breathing. So if this muscle is weak, we're going to have hypoventilation. So when we have hypoventilation, what happens is we're taking short and rapid breaths. So you can notice sometimes in kids with spinal muscular atrophy a kind of breathing that it's like fast and shallow, fast and shallow. What happens with that is if we don't really take big breaths and ventilate our airways, the lower lobes don't get enough ventilation, and then the air sacs on the lower airways can get shut down and collapse, and that's what we call atelectasis. So maybe you go do an x-ray if your kid is sick and they say, well, we can see atelectasis. So that's basically what it is, atelectasis. It's just collapse of that little air sacs. But the problem with the atelectasis is that it's going to cause hypoxia. So the kid will need to come into the hospital to get a treatment for that hypoxia. So how is the breathing in patients with SMA? So on the left, you have just a diaphragm demonstration of how all of us breathe. So the way we breathe is we take air in by contracting the diaphragm contracts and comes down, and then the sternal-intercostal muscle will contract and bring the chest up and out, and that's the way the air comes in. So what happens is if we have, in spinal muscular atrophy, we have a more stronger diaphragm than the intercostal muscles, and then when the diaphragm contracts, the intercostal muscle cannot handle the pressure and they collapse. So probably you have here the pediatrician or me or Dr. Finkel say one time, your kid has paradoxical breathing. So the paradoxical breathing means that when the patient is taking air in and contracting the diaphragm, the chest wall is collapsing. So it looks like a zigzag breathing, looks like this. So that's the reason why they breathe like that. What's the issue with that kind of breathing is that it causes fatigue of the muscles, but the other thing is that they can have chest wall deformity. So they can have the bone in the center of the chest, called the sternum, can dip in with time, and then they will develop, the bell-shaped form of the chest. And then we tend to do several things to help to modify that, and we're gonna talk about that in a little bit later. So let's just in a nutshell talk about each of the issues and what we do. So let's start with bulbar weakness. So when we have bulbar weakness, as I said before, my concern is aspiration. If the issue is aspiration of saliva, which I see a lot, is the symptoms will be that the patient drools a lot and is not able to handle their own secretions. And like Kelly was saying, some of the symptoms may be the clearing throat, sounding all the time, like having all of that saliva there, and sometimes they can cough. If we have that problem, we really might make sure we handle the saliva. So the way we do that in pulmonary is medications that will dry them a little bit, but not plug them. So we have to have a fine balance between giving medications that will dry the saliva, but be careful that the mucus is not so much dry too. So we use something called glycopyrrolate, which is a medication, Robenol. We use the scopolamine patches. This is just the patches that people buy when they're going to the cruise and they put it here for motion sickness. We use that for control of saliva. Right now, interventional radiology is doing Botox too, injections on the salivary glands. I have a couple kids of my patients using this, not all of them, but it's also something to consider. When the problem is aspiration of food, we have a very proactive approach with speech therapy. We order swallow studies, and we will do modifications to help and prevent aspiration. Sometimes it may require more aggressive things like a G-tube. The aspirations can happen from above, which is what we have been talking about, but also can happen from below. So aspiration can happen when the patient has reflux, and then when they have the event of the acid coming out, they can have microaspiration of that acid. What happened with the aspiration is that people may think it's not a big of an issue, but it is, because with time, little insults to the lungs, time by time, are going to create a big deal of pulmonary inflammation and then fibrosis. So what happened to the lungs is with the fibrosis, they become more stiff, and then you can imagine how hard it is to really expand those lungs. The other damage is to the airways itself. When the acid or the food goes the wrong way, those bronchi can suffer permanent damage. That is called bronchiectasis. And as the nutritionist was saying, we can have kids that have silent aspiration, and I think that's the one I worry more about, because they don't really cough or they don't sound like they're having trouble, but you do a swallow study and you see that they aspirate. So to review the cough mechanism, when we cough, we basically contract the diaphragm strongly. So we take a big breath in, and then we close the glottis, and then we have contraction of the diaphragm, intercostal muscles, and abdominal muscles, and that pressure gets really, really, really strong inside of you, and then you release the glottis, and then it's when the come out. One of the pulmonary issues that we see in patients with spinal muscular atrophy is actually the weak cough, and this is something I'm very aggressive at handling. Why? Because when they're sick, they produce more secretions, and that this can be much of an issue. The way I handle issues with cough is using a device that will cough for the patient and will do the mechanism of what the cough is supposed to do. So talking about that, the approach in the pulmonary world for that is the cough assisters. So basically there are two big approaches that you will probably hear of, which is the cough assist, the cough assistance, and the proximal airway clearance. And then we have the distal airway clearance machines that are the VEST and the IPB. So I had to say about this, the data about cough assist in spinal muscular atrophy is weak, but the consensus of experts is very strong that we have to use this, and it has to be added early in the disease. So basically, I have little babies on cough assist. It's protective of the airways. The data shows that it decreased the days of admission to the hospital, decreased the atelectasis, and decreased the chances of getting pneumonias. And some of my patients here will probably know how OCD I am about the cough assist. So when we talk about cough assist, it can be done manually or mechanically. So there are two ways we can do this, machines or no machines. So when we choose the manual form of airway clearance, it can be challenging when we're talking about little kids, because it requires somebody that is really skill of doing it. So what we usually do is we use something similar to an ambu bag, but it's just a one-way valve. So that's called an insufflation valve. So what we do is ask the patient to take a breath, and then with that mask, we basically make that breath bigger, giving insufflation and make it a bigger, bigger, and bigger. And then when we ask the patient to cough, and then we assist the cough by putting pressure on the diaphragm and pushing the diaphragm up in order to make that cough stronger. In little kids, especially kids that have reflux, kids that have a G-tube in place, kids that have an Nissen, this can be very traumatic and very uncomfortable. So we do more the mechanical airway clearance. So we use the machines more than do anything manually. The evidence of using the manual versus the machine is really not that strong that one is better than the other. But if you are not skilled, it should be better to use the mechanical ones. So this is 3 different devices. We have different companies, different insurances. It depends on your insurance, the one that you're going to be able to get. I like the T70 a lot, which is the one that looks like a little square microwave, the black one, because this new cough assist device has been able to have an upgrade on it that I can add oscillation. So that means that, so the way these machines work is they give you a big insufflating pressure, so they inflate the patient, followed by a very rapid exsufflation. So they will do what the cough is supposed to do. I tell my parents all the time, the machine is not gonna make the kid cough. That's not the goal. It's gonna replace what the cough is supposed to do. So, but what is particular of the T70 is that with a little SD card, we can make the patient oscillate on it. So when the patient is inhaling, the machine will be doing the inhalation, and then at the same time will do vibrations of the airways, breaking the mucus. And I think it's one good adding to the machine, because that's what probably the best, the little vest with the vibration oscillation that we use a lot in cystic fibrosis, that's what really it does, is oscillatory pressures. So this is the other mode, which is the sputum mobilization. It's for more peripheral airway clearance. And I had to stop here and say, because I get so many, not from parents, but more from other physicians asking me, should we order a cough assist? Should we order a vest? So the consensus on spinal muscular atrophy is that we should use a cough assist initially, not really a vest. Because remember, the issue is cough, so we want to use cough augmentation techniques, because the issue with this patient is that the secretion will stay on the central airway. So the evidence is that we really want to do cough assist devices. When I have introduced vest to some of my SMA patients, but I use the vest for kids that have already been maxed out on their cough assist. That means that they're using it appropriately. We are going up on pressures. They're maxed out. I cannot give more pressures. And the kids still have some atelectasis on x-rays, still have, pneumonias here and there. So then I add this as a support, but one will not replace the other. So when we are using a vest for distal airway clearance, the secretions will come from more distal airway to the central. We need to still use the cough assist after. So it's a 2-step, it's not a single step. The other one that I'm putting in this picture is the IPV. It's kind of new, it's not really old. We use this a lot for cystic fibrosis, but it kind of do the same. It's used via mask, mouthpiece or a mask. It will deliver little mini bursts of pressure, so it will be like, and that way it will give oscillation to the airways. The IPV in the hospital setting is very good and very powerful, and some of my spinal muscular atrophy patients that have been admitted, I use it, but I don't order for home because the home device is very weak, so I really don't like it for home. So the other pulmonary issue that I work with is sleep problems. The patient that has spinal muscular atrophy will have initially We can see obstructive sleep apnea because of what we talked before, and then over time, they can develop hypoventilation. So the sleep problems on spinal muscular atrophy present usually during REM sleep. That's deep sleep, that's active sleep, when the eyes are moving like this. They will have issues with the oxygen. At that point when they're sleeping, oxygen drops, the CO2 goes up. And this is gonna cause the patient to wake up because we have central receptors in our brain that actually sense when the CO2 is going up. So what happened is this is a circle of problems because we have a patient waking up at nighttime a lot. Then the sleep efficiency, which is really the amount of time the patient rests, will go down, and then we're gonna have a kid with sleep deprivation. The problem with sleep deprivation is that when you're sleep deprived and you go to sleep, actually you're gonna go to REM faster because that's the way your body's gonna try to compensate. So if you go to REM faster, then you're gonna have more problems. With time, what we see is when things start, we don't approach this like earlier and we don't detect the problems and put the patient on positive pressure on a BiPAP, and the problems continue, what we tend to see are patients that will start responding to that high CO2, and then they're gonna start developing all these problems during times they're awake. So this is what we call chronic respiratory failure. So what we do is my protocol is I screen my patients every 6 to once a year. I do a baseline sleep study, and after that, depending on the results of that baseline, I will repeat every 6 months or once a year to be able to detect problems earlier. The pulmonary care of patients with SMA has turned around to be a very proactive approach. So you don't want to wait until the problems come, you want to be before. You want to use cough assist before the patient can be very weak. You want to do a sleep study and see the problem before they start getting worse, because that's the best outcome of the patients. So when we have sleep disorder breathing, we use non-invasive ventilation. And as I said before, I'm using a lot of this now. We barely are seeing trachs and vent patients at this point, thanks to the new changes on the SMA world. So the goals of the non-invasive are basically treating these sleep problems. But the other thing I empower my parents to do is, if your patient is sick, you can use these devices. You can use the BiPAP at home during the time they're awake to give them breaks. When the kids with SMA get sick, they start breathing faster and they get a lot of muscle fatigue. So when we use the BiPAP, we give them breaks and they do much better. So this is an amazing thing about the BiPAP, that is keeping kids away from the hospital much more than before. The other thing is, when we talk about the way they breathe and the paradoxical breathing, I mentioned that it can cause chest wall deformities, the pectus, the bell-shaped chest. So the non-invasive actually has proven to kind of modify that a little bit. So the non-invasive pressure, we use it to give those big breaths at nighttime, and we can avoid the rapid development of deformities of the chest. And of course, the non-invasive is there to prevent the invasive. So if we are able to keep the patient stable on BiPAP, then we don't have to think about a trach and a vent. There's so many, and I kind of feel, Lisa is here, she's the head of the sleep lab. This is just 3. She has probably tons and tons of different interfaces, from nasal mask to full face mask, there's so many things that we use in the sleep lab. And we will do everything, we try everything to make the patient comfortable in order to see what's better for them. What we want to try to avoid is avoidance of the maxillary hypoplasia, so the face can keep growing, and the skin breakdown. When we see skin breakdown, we're very proactive at changing the interfaces in order to avoid those face problems. So this is the most important topic for me, and I think I drive crazy my parents with this on and on and on every time they come, and is how are we going to manage the respiratory infections? I think the success in the care of spinal muscular atrophy from a pulmonary standpoint is that you know what to do in your house. If your kid gets sick and you don't know what to do, we failed. I failed. So what I do is, my patients, they will have a sick plan and they will have a healthy plan. So, and basically that will include, okay, so if he's okay, you're gonna use the cough assist probably twice a day. If the patient is sick, you're gonna start increasing your cough assist to 3, 4, 5 times a day. And then, and the nebulized medications, the data on this is actually not so good. So the way I handle nebulized medication is, if I have the evidence that the kid has reactive airways, that means if I have the evidence that the kid gets sick and actually twitch their airways and wheezes, I will use albuterol on the patient. If I don't, then I will probably just use saline to keep the secretions like a mucolytic, to kind of break down the secretions so it's easy to cough them up. And then the other question are inhaled steroids, and it's the same answer. If the patient has twitchy airways, I will probably consider inhaled steroids, but not in kids that don't show those symptoms. So the sick plan that I design for my patients will include, okay, use the BiPAP when the kid is sick, increase your cough assist, and add this or that medication that he will need. And of course, I always tell my parents, if, the kids is not better in 24, 48 hours, you can call me, and we, over the phone discuss what things we can do to make it better and avoid the hospital. So on this image here, I want to show you the one that have the 4 together. That's a bronchoscopy. So when I take the patient to the OR and I use a bronchoscope through the mouth, in the airways, I'm able to see the amount of mucus accumulated. So that's a patient with a mucus plug. So that's how a mucus plugs look. It basically blocks the airway. So it's the airways of little kids is actually very little. I have to use very tiny scopes to be able to bronch a patient when they're little. So you can imagine, even when it's not a big deal, mucus plug, it's a big deal, and it can block the airways of these kids. That's why it's so important. I'm so emphatic about how important it is to keep the secretions moving in these patients. And then, so prior to surgery, I'm very cautious about this, and I almost all the time see my patients before they get anesthesia and a surgery, because I have found a lot of success in my practice creating a pre-op plan for these patients, which is actually similar to using a sick plan. So for 7 to 10 days before anesthesia is gonna happen, these patients are gonna be doing 1, 2, 3, 4. And then one of the things that is very important that we do a sleep study before they're going to go for anesthesia, especially if it's going to be a long surgery, scoliosis surgery. I want to make sure if this patient needs a BiPAP, so we can first order it, have it ready, and also makes the patient comfortable with this, because of course this is kids, and having a mask in the face can be uncomfortable. So we want to have time for that patient to decondition from the mask. The other thing is we have to make sure patient is gaining weight before they're going for anesthesia. Some kids may need to see cardiology, some others not. And the other important thing is that anesthesia needs to be comfortable with the patient. I get staff messages all the time from anesthesia, and they ask me specific questions. I think the spinal muscular atrophy patients needs to be seen one by one. I'm concerned about the airway of the patient. Does this patient have a little bit of problem opening their mouth? It's going to be a hard intubation. All of those little details are not little, really. I think that we have to address and be very careful. So I think the success on a pulmonary care of patients is, number one, be very proactive. You want to make sure that you really screen your patients. I see them twice a year, sometimes more if it's needed. Be sure that you handle sickness aggressively, and make sure that you don't let go sleep disorder breathing, because this can get better, they can get worse very fast. And so I put together everything. This is a nutshell of the pulmonary care. Do you have any questions? Any questions?
That's right here.
Yeah.
Coming, Ray.
When the patient is well, you recommend 2 times a day to perform the cough assist?
Yes. So the cough assist is, and the way I present it to my parents is like watching your mouth. in the morning and nighttime. So you want to clear your airways in the morning and at nighttime. And if they're sick, they're going to increase it much more.
Maybe a duration of 5 minutes or
Okay,
15
so the cycles, and again, I tried to do this very little, but the way we use the cough assist is if you're introducing this for first time, we need to work with that because little kids will be very apprehensive. It's uncomfortable. It's not a comfortable feeling. It's putting pressure on your face. So what we do is when we order the equipment, we tell the company lower pressures than what we think the patient will tolerate, right? So we start slowly with lower pressures, and then we say, okay, try to do 3 cycles of 5 breaths initially. And then the goal is actually 5 cycles of 5 breaths. That's the goal. So what I try to do is every time a patient of mine will come to my office, they will bring the equipment, and then we'll twitch pressures up. And we will see how, because remember, on the cough assist, you can play with inhalation and exhalation time. So sometimes what I see, especially in little babies, is that when you try to put air in, the patient is exhalating. So you're really not matching the breathing. So they feel suffocated and uncomfortable. So what we do is we do little changes on the office. We kind of study the way they're breathing. And then we twitch the machine, changing the inhalatory, exhalatory time to match more or less what the kid is doing, and then increase the pressures slowly by slowly, every 6 months.
Now, how often do you recommend changing out that mask for the cough assist and the tubing for the cough assist?
Yeah, so the companies will send you every 6 months supplies. Every time my kids come to the office, they get a mask from me. So they get more because I have them and I give it to them. But it's usually every 6 months. It should be clean after each section. If they're sick, they're gonna bring mucus to the mask probably, so you really wanna make sure you can use vinegar to clean it, basically.
Thank you.
All right, any other questions?
All right, guys, we don't have time for questions right now, but if you want questions afterwards, you can ask Dr. Navas, but give it up for Dr. Navas, guys.